All right, let's dive right in. Today, we're tackling a classic surgical viva case, the anal fissure. I'm going to be your examiner, and we'll walk through exactly how to structure your thinking, lay out a clear plan, and, most importantly, handle those curveballs that can really make or break your performance. Ready? Let's go.
Right, candidate. Picture this. You're in the hot seat. A 28-year-old man comes in with severe perianal pain. It's been going on for 3 days. The clock is ticking. So, how are you going to approach this patient? Remember, what I'm looking for is a safe, logical framework, not a panicked guess.
So here's your opening line. Nice and calm, you'd say, "Thank you. I'll approach this patient systematically. I'll start with a focused history, then a thorough physical examination, and from there, I'll formulate a differential diagnosis." See, you've immediately established your method. It shows you're safe, you're organized, and you have a plan. Okay, first things first. We have to gather our information. This is the bedrock, the foundation for the entire case. Let's get it right. As the examiner, I'm going to push you for more detail. Excellent start. Let's really drill down on the history. What specific questions are you going to ask about his pain? I don't want a textbook list. I want to know what you'd actually ask the person sitting in front of you. And as the candidate, you need to show you're structured. You'd say, okay, I need to fully characterize this pain. First off, when did it start? Can you point to exactly where it hurts? What does it feel like? Is it a sharp, tearing sensation or more of a dull ache? And then, the crucial one, tell me about its relationship to having a bowel movement. Finally, you have to ask, have you noticed anything else, like bleeding, a fever, or any discharge? So, as the examiner, I'll give you those classic findings. Okay, candidate. The patient confirms it, sharp, tearing pain with defecation, and he's seen a bit of fresh blood on the toilet paper. Now, what are you going to look for in physical examination? Your answer here has to stay systematic. You'd say, first, I'm just going to look at the patient's general appearance and check their vitals. Any signs of distress or sepsis? Then, a quick abdominal exam to be thorough. After that, the focus is on the perianal area. I'll gently inspect for any visible fissures, sentinel piles, or maybe signs of an abscess. A digital rectal exam is important, but, and you have to say this, it should only be done if the patient can tolerate it. You don't want to cause excruciating pain. Now, as the examiner, I might throw in a clinical pearl here, a real high-yield tip. Remember, candidate, most fissures are posterior, right in the midline. If you see a lateral fissure, that's a huge red flag. You need to tell me that you're immediately thinking about more sinister causes, like Crohn's disease, malignancy, or maybe a serious infection. So, we've gathered our data from the history and the exam. Now it's time to put it all together and form a coherent plan. And as the examiner, that's my next question. All right, based on everything you found so far, what's your differential diagnosis? I want to see you connect the dots. As the candidate, you'd answer, while my leading diagnosis is an acute anal fissure. But there are other important possibilities I can't ignore. It could be a thrombosed external hemorrhoid. Those can be incredibly painful too. Or we could be looking at a perianal abscess, a fistula in ano, or even a perianal sign of inflammatory bowel disease. So you confidently state your main thought. My provisional diagnosis is an acute anal fissure. And in a case that seems this straightforward, you don't need a laundry list of investigations. A simple, complete blood count is a really sensible place to start, mainly to check for a high white cell count, which might point us more towards an abscess instead of a simple fissure. And here we are at the absolute core of the Viva, your management plan. This is where you really show your knowledge, from simple advice all the way to the operating room. As the candidate, you have to present this as a clear, stepwise approach. My management would be stepwise, always starting with the most conservative measures. First, lifestyle advice. A high-fiber diet, drink more water. For symptoms, warm sitz baths and simple pain relief are great. If that doesn't work, we step it up to topical agents like GTN or calcium channel blocker creams to help relax that sphincter. And as a final non-operative step, we could consider a Botox injection. But of course, in an exam, the easy stuff never works. So the examiner says, medical management has failed. It's been 8 weeks. The fissure is now chronic. What is the definitive surgical treatment? Give me the gold standard. As the candidate, you say with confidence, the gold standard surgical treatment is a lateral internal sphincterotomy. And then you explain it simply. I'd tell the patient the goal is to make a small, precise cut in the internal anal sphincter muscle. This releases all that excessive tension, letting the fissure heal by improving blood flow. And then, critically, you have to add, I would also have to counsel them on the small but very real risk of minor incontinence. That's a key part of the consent process. The examiner might then say, talk me through the steps. So you do.
First, a formal timeout. Then I'd do an examination under anesthesia to confirm everything. A small incision is made in the intrasphincteric groove. The internal sphincter is carefully isolated, and then it's divided just enough to release that spasm. We close the wound with an absorbable suture. Post-op, the patient continues with sitz baths and pain relief, and I'd see them back in clinic in 6 to 8 weeks to make sure it's all healed.
But a good viva is never that straightforward. A sharp examiner is always going to have a twist waiting for you, just to see how you handle the pressure. So here it comes. As the examiner, my tone gets more urgent. Candidate, your management has failed. The patient is back. They are septic, and they have a fluctuant perianal mass. What do you do now? This isn't an elective problem anymore. This is an emergency.
As the candidate, you need to sound decisive. Okay, this is now a surgical emergency. My priority has to shift immediately. We're no longer just treating a fissure, we're managing perianal sepsis. This patient needs urgent admission, resuscitation with IV fluids and antibiotics, and an immediate trip to the operating room for an incision and drainage of that abscess. The focus is 100% on source control.
Okay, let's step out of the hot seat for a second. We've navigated the case, we've handled the twist, and now we can debrief on what it really takes to pass a station like this one.
This quote from Bruce Lee says it all, doesn't it? The kind of smoothness and confidence you need in a high-stakes viva doesn't just happen by luck. It comes from relentless practice. You have to rehearse these scenarios over and over until that structure is just second nature.
So what are the big take-home principles here? First, always be systematic. That's your safety net. Second, you have to nail the basics of history and examination. Third, always build and clearly state a logical differential diagnosis. Fourth, show that you understand the ladder of treatment, escalating from simple to complex. And finally, you have to be ready for complications and prepared to pivot your entire management plan on a dime.
And with that, you've passed the station. But the learning never stops, right? As you get ready for your own exams or even just your next clinical encounter, which one of these principles are you going to focus on to make your own work more skillful, swift, and steady? It's not just about knowing the answers, it's about having a system. Thanks for joining me.